All right. Welcome, everyone. My name is Brian Blethen. I'm the Senior Director of Practice Operations here at Lincoln Hospital. I want to welcome everybody from the community that's joining us tonight to MaineHealth Lincoln Hospital here in Damariscotta. We're very lucky to have a presentation from Dr. Lee Laufer, our dermatologist here. Again, just want to welcome everyone to Lincoln Hospital and appreciate you joining us here. We've done several events similar to this, and we hope to continue to do them in the future where we share great things happening across MaineHealth as well as here specifically at Lincoln Hospital. We have practices in Waldoboro, Wiscasset, Boothbay, as well as here in Damariscotta, and are proud to serve this community in all of those capacities for both specialties as well as primary care. So again, just want to welcome you and thank you for joining us. So one of the great things that I get to do here as a practice operations leader is I get to go out into the community large, the United States as well as around the world, and recruit great physicians and nurse practitioners and PAs to come and provide the great care to you all. And a few years ago, I think it's 2022, yep. I had the good fortune to meet Dr. Lee Laufer, who was wrapping up a very successful practice of 30 years down in New York, and is a member of the Dermatology Academy, right? And so decided that he wasn't quite ready to hang up the stethoscope and hang up the white coat. He wanted to come to Maine and enjoy all the great things that we have to offer here, our great community, our great natural resources, and help us advance our dermatology program here at MaineHealth. Shares time not only here but also with a practice down in Portland. So it's a very collaborative effort across the whole MaineHealth network. But very, very proud and privileged to have met him, to have helped him join this team here. He also works with Misty Day, who is a nurse practitioner in the practice. And Misty is another great example of opportunities that we have here. And Misty worked, I think originally had worked as a CNA over at Cove's Edge and then became a nurse and had worked in some of the different departments here, and then now is a nurse practitioner in our dermatology practice. And Lee and Misty make a fantastic team, so very happy about that. But without further ado, I would love to introduce you to Dr. Lee Laufer, who is not only an amazing dermatologist, but one of the most environmentally friendly and kind people I've ever met. So, Lee, I'll hand it over to you.
Hello, can you hear me?
Yeah, so that's for the camera.
Oh, for the camera, okay.
Yep.
All right, so I'll speak to all of you instead, which is far more delightful. So thank you all for coming. I appreciate it, and I'm honored to be here. And I welcome any questions, some of which I will hopefully know enough to answer. So I'm grateful. So anyway, do any of you have any questions before I start? Oh, maybe we'll save it for after. But it was good. So basically, the things that we're going to discuss today briefly are moisturizers, the different forms of moisturizers, sunscreens, their history and applicability, skin cancers of various sorts, and we're going to just discuss the three most common ones for the sake of brevity, and the ones that are, of course, by and large, the most significant, and the environment in terms of things in the environment that can cause photosensitivity and, ultimately sunburns. And then I, of course, welcome your questions. So why don't we go to the next slide? So the reasons that we moisturize are a multitude. I mean, I think we feel better when we moisturize. There is a skin barrier that exists in all of us, which is composed of a variety of things in terms of essential fatty acids and other things. And these barriers are challenged often by environmental stresses. And so you can dry yourself out when you wash, and especially if you wash excessively or use more caustic soaps. And the frequency of washing obviously will impact how well you're able to hydrate. But if you moisturize after each wash, you'll find that you'll probably have, a better feel in your skin. But what it corresponds to from a clinical point of view and a chemical point of view is that this skin barrier that essentially protects us from the outside world, when it's properly moisturized, is more functional and intact. And we've seen studies that suggest that if you have an intact skin barrier, the risk of sunburn actually declines, and the risk of sun damage does. So it has photoprotective effects intrinsically. And when it's compromised by a variety of environmental factors, whether it's excessive washing or sweating a great deal, being in a chlorinated pool or whatever, that its natural functionality is impaired. So what I like to do is to look at making sure that we adequately moisturize. There are three general classes of moisturizers. Humectants are really interesting in that they attract water to the skin, sometimes from the deeper layers of the skin or from the air. And that's really unusual, even exceptional in that stronger humectants can actually attract up to 1,000 times their net weight in water, which is enormous. They're essentially like sponges. So there are a variety of chemicals that you can see if you look at what you're using. Glycerin, aloe vera, honey, which is interesting, a natural humectant that can help you moisturize and soften the skin. Urea is very, very helpful, as is lactic acid. And these are used actually in many clinical applications when people have psoriasis or eczema, and therefore their skin barrier is not intact. And this really augments the effect of other medications. And it also enhances penetration because the natural transmissibility of these medicines through the skin barrier is enhanced when it is intact. Alpha hydroxy acids, which many of you may have heard of, will exfoliate and serve as humectants as well. So they moisturize, they enhance the skin barrier, and the exfoliation is actually a way to promote that. There are a variety of other things, sorbitol, which is a sugar alcohol, and a whole bunch of others, but these are the major ones. Emollients, basically serve to enhance moisturization by smoothing and softening the skin and filling in gaps in the structure of the skin that may occur when you get too dry. Shea butter, ceramides, fatty acids are the sort of exemplars of that. And then you have occlusives, and for occlusives, many people don't like those, but if you have really, really dry skin, they're actually the best way to go. Petrolatum, mineral oil, silicones, and then a lot of the natural oils like olive oil are occlusive. So the former two may be better if you're on the drier side or a normal skin tone. But when you're extremely dry or you have medical issues, the occlusives are probably going to be more effectual. So anyway, let's go to the next slide. Oh, I think we skipped. So that's basically my spiel on moisturizers, to keep it brief. Sunscreens are really interesting in that they have a very, very long history. This dates back actually to ancient Egyptian times, millennia ago, when the ancient Egyptians used, interestingly enough, lupine here in Maine. Lupine as a moisturizer. They used a variety of other things as well. And I think that the ancient Greeks used sand and oils of various sorts. So the other thing that's interesting is that as the modern era arose, we had the initial sunscreens developed by a guy named Frederick Hammer in 1891. Significant advancements followed with the invention of the sun protective factor, which occurred in 1974. And this was limited to ultraviolet B radiation. And to this day, there is no quantitative metric for ultraviolet A. So these wavelengths are quite different in that ultraviolet B is what's implicated in the development of basal cell carcinoma and squamous cell carcinoma, which are the two of the more common skin cancers. And ultraviolet A is implicated in melanoma and inducing melanogenesis and atypia. So we've been sort of begging the FDA for a couple decades now to come up with a quantitative system that is sort of universally accepted, and they've not yet done so for quantitating the strength of an ultraviolet A block. Well, so we have this sort of rubric now, which is, a general rubric that we call them broad spectrum sunscreens. And we just don't know how broad those broad spectrum sunscreens are, because we don't really know quantitatively how effective the ultraviolet A component is. We know how effective the B is. And remember, when you have a number for your sunscreen, if it's, let's say, a 15, if you would tend to, with no sunscreen, go out and get a sunburn or get red from the sun after 20 minutes, for argument's sake, a sunscreen factor of 15, in theory, should mean that you have 15 times longer than that 20 minutes in order to then generate redness or sunburn. The problem is that there is a quantitative drop in the significance of the SPF that is exponential based upon the amount you're applying. And so the initial studies were done with 2 milligrams per centimeter squared of sunscreen. But the average American applies 0.5, 1/4 the amount. And so if you look at it on an exponential basis, you're looking, a 15 sunscreen may be equivalent to a 2 or 3. So there's a problem there in that nobody lubes up so heavily. It's like using half an entire tube of 8 ounces of sunscreen to cover your body. So this is one of the reasons why many of us suggest at least a 50 sunscreen instead of a 30. Although most, studies suggest, do a 30, it's fine. It depends on how long you're out for. It depends on whether it's water-based or oil-based. It depends on whether you're swimming or sweating and so on and so forth. And so each of these sunscreens is somewhat unique. And so what I would recommend you do is to just make sure you read the label, because it should define the frequency of application. Classically, you would do it 15 minutes before going out. This gives you optimal penetration, and then reapply every 2 hours. But with the caveat that if you're swimming or you're running or you're exercising, or if it's a really, really hot day like yesterday or today, and you're sweating profusely, you may have to do it more frequently. And usually those instructions are going to be present in the sunscreen. So that is, a significant issue. So let's go to the next slide. So we have basically 3 skin cancers that are most common here. Basal cell carcinoma being overwhelmingly the most common and the least dangerous of the 3. Squamous cell carcinoma sort of rests in between, and malignant melanoma is the most significant one in terms of both mortality, morbidity, but its frequency is less. So 1 in 5 Americans will develop skin cancer on average in their lifetimes, which is a fairly amazing number. 3% of, whites or Caucasians will develop skin cancer per year. If you're African American, it's 0.1%, and if you're Hispanic, it's 0.5%. So there are racial differences, in large part contingent on the amount of melanin people have, which is photoprotective. Basal cell carcinomas represent, 80% of all skin cancers. There are 3.4 million on average per year of those in the US, 1.8 million squamous cells and 200,000 melanomas per year. We are fortunately making some inroads with the advent of checkpoint inhibition and a variety of other immunologic mediators that have rapidly advanced this field with melanoma. And so it's been declining for the last 5 or 6 years at about 4% per year, but we're still at about 8,400 people expected this year to die from melanoma. You may remember that Jimmy Carter had a malignant melanoma with metastatic lesions to the brain. He underwent radiation therapy and then went on novolimumab, which is a checkpoint inhibitor, and that cleared him. And he didn't die from melanoma, even though it was diagnosed 10 years before his death. And so this was unheard of when I went into residency, in the middle 80s, middle 80s, because we didn't have that. We had interferon alpha. The median point from metastatic disease to death was 8 to 9 months, and now we're measuring it in many years to decades for many people. We actually are able to establish what we feel, at least at this point, is clinical cures in a number of people. So this is a revolutionary change. So in general, we do see deaths from basal cells and squamous cell carcinomas. About 3/4 of the 2,000 people who die from non-melanoma skin cancers will die from squamous cell carcinomas because they're far more aggressive, and they are particularly so in areas of vulnerability such as the lips, the eyelids, the ears, or arising in scar sites. And these are called, sometimes marginal ulcers when the skin breaks down. These are clearly, lesions that you need to be careful with. If you find something arising on your lips, on your ears, bring it to the attention of your provider or try to get an appointment with me. So, 3/4 of the 2,000 deaths are from squamous, and of course 1/4 are from basals. And we now have ways of treating metastatic squamous cell carcinoma as well as basal cell carcinoma that are unique and have arisen in the last decade or two. The squamous cell carcinoma actually medication was approved actually in the last 12 months. But we have Eravige, which is a great medication for treating metastatic basal cell, and I've had quite a lot of success in treating non-resectable basal cells with it and metastatic basal cells as well. So the clinical features that you might want to look for these, basically these are often little patches that are flat, that glisten a little bit in the sun, and if you press the skin apart, you can sort of see them glisten. They often will have arching vessels. I mean, this is a bit of a magnification, and what we do in the office is we use polarizing microscopy to look at these, and we can get much clearer images of them than you can with the naked eye exam. But if you have a new lesion that's arising, it's often pink, although there's a subclass called pigmented basal cell carcinoma, and these have grays and light brown hues to them. Squamous cell carcinomas often arise in two forms. One is in situ and the other is invasive. The invasive, which is present here, is usually a central nodule with an area of hyperkeratosis in the center. We call them crateriform dermal nodules with hyperkeratosis centrally. And these lesions can grow either very slowly or very rapidly, depending on their level of differentiation. Poorly differentiated squamous cells can sometimes arise, de novo in a couple, 3-4 weeks and become a centimeter or two in size. So these can be quite high risk. And there's a whole range of variability. We've had some people who refuse treatment or just elect for observation for whatever reason, and these lesions will sit indolently for a decade. And the same is true, of course, with basal, but basal is much, much less aggressive in general. And then for melanoma, maybe we'll go to the next slide. Basically, what we're going to deal with here are, from a lay point of view, the ABCDEs of moles. And these are a way of us defining to people what happens when there's a loss of growth control. And I always think of when there's a loss of control and a lack of organization, I think about the stars. And I think about exploding nebula. And the fact that something is just not symmetric and the internal structures are not organized. And so in a melanoma, you're going to get disorganization. So in this example here, you can see a nodule here that's dark, and you can see a flat area, macular area here, that's perhaps slightly different color. And this is a nodular melanoma arising within an area of in situ melanoma, and in situ melanoma means it's confined to the top layer of the skin, whereas the nodular component is going to reach down into the dermis, and that's where your relative risk goes way up. Because once it's invaded through the dermal epidermal junction, the junction between the top and middle layers of the skin, then you have a risk of metastatic disease. And the deeper it is, the larger the tumor volume, and a variety of genetic factors that are a little bit beyond this talk scope, but that will determine its relative risk of metastatic disease. So asymmetry is one of the sort of foundational things that you would look for in a lesion. Let's go to the next slide. So going back to the idea of loss of growth control. So your borders in a benign lesion where there's normal and controlled growth should be relatively even and symmetric. Whereas in a melanoma or in a typical mole, you can have notching, scalloping of the borders. So they're not only, not symmetric, but the borders themselves are irregular. Let's go to the next slide if I can show it. Next slide.
Whoops, we missed C.
I think you missed, yeah. We missed 2. Okay, here we go. So color is another issue. And again, this goes back to a loss of growth control. when the amount of melanization in a particular component of the lesion is normal, it's uniform. And so in a normal junctional nevus, a mole in the top layer of the skin, things are relatively even. Now there may be two colors here, a little light rim and then a darker center. But if you look at it and you were to break it up into the X and Y axis, these are iterating symmetries, and in addition, they're superimposable. So if you flip this half on here or that way, they're completely symmetric. So that speaks about the benignity of this lesion. Here, you have multiple colors. And the colors that we worry about, we'll call them patriotic colors, red, white, and blue, and then black, gray, and pink. The more colors you have, the more you should be concerned. So by the time you get to 5 colors in a lesion, you have a 70% chance it's a melanoma. So if you see a lesion that has multiple colors, bring it to our attention. We do have, by the way, for people who are, in our queue or on a waiting list, a nurse who will do dermoscopy for us. And they'll take the dermatoscope, which is this device, and they'll attach it to an iPad, and they'll take microscopic photos so I can evaluate them. And that way we try to go through the patients who have concerns, even before we've seen them, to make sure we're not missing somebody who might have a problem that has to be acted on immediately. Because right now there are, I guess, 1,100 people in our queue, and I'm booking out a year and a half. So we want to make sure we don't miss anybody who's still waiting. And this is one way to do it. Anyway, so these photos will come to me and I will evaluate them and then say, yes, this person needs to be seen today or tomorrow, or I'll see them when our next available skin exam is, because this is totally benign. They have nothing to worry about. At any rate, so color is significant. And I just had a lesion that had 7 colors, and it was an invasive melanoma. Anyway, so let's go to the next one. So this is a little antiquated because they've changed the criteria. The old criteria were a lesion greater than 6 millimeters. And when you've started to do dermoscopy, you can start seeing things that you can't with the naked eye. And they've looked at studies which suggest that dermatologists who are expert in it have about a 92% rate of recognition of melanoma, and those who do not use this technique are in the high 70s. And general doctors who are not trained in derm are about 50%. Anyway, so the thing here is they've changed this criteria. I mean, I had one melanoma, I remember it was an invasive Clark's level 3 melanoma in a patient on his right thigh about 15 years ago who'd had a prior melanoma, and it was an incredibly atypical lesion. It was 0.8 millimeters. So, it was smaller than this, designated amount. So the 6 millimeter criteria is a fairly weak criteria. So it was changed to dark. But understand also that there is a subclass of melanomas, desmoplastic melanomas, and melanotic melanomas that don't have much in the way of pigment. So just because it doesn't have a lot of colors alone is not sufficient. There are subclasses of melanomas that can squeak by when you use just those criteria. And sometimes you need dermoscopy to be able to establish that difference, because they can mimic basal cell carcinomas and they can mimic other things. So anyway, let's go to the next slide. There we go. So the other criteria we should look for is things that are evolving and changing. If you have a lesion that is stable, that sort of speaks for the fact that there may not be as much loss of growth control as you might be concerned about. But if it's changing, especially most of the studies suggest right now 26 is when you can have lesions that are changing. But the fact of the matter is that in doing long-term digital photography of patients, we're seeing now lesions changing all over the place in large numbers of people in their 40s and 50s. But they're not necessarily clinically significant. So it's really much more complicated than we originally thought. We have this device called PhotoFinder down in Portland where we take full body photography, and I had a system back in the 90s at my office I sort of conjured up with some computer guru who figured out how to do this at the time when we were still dealing with analog photography. And anyway, but this is what we're finding, is that things do evolve and they're not necessarily significant. But if you see something evolving, prudence would dictate, bring it to our attention. Anyway, so let's go to the next slide. Any questions on that before I go further? So there are a bunch of things in our environment that can cause sunburns, just so you're aware. And giant hogweed, I had one person who had giant hogweed dermatitis, and it was amazing. It looked like a 3rd-degree burn. Thank God she was a gymnast, and she was really sedulous about treating it, and she ended up with no scarring. But I really was almost convinced she would have some scarring, and she didn't. But this stuff is vicious. I mean, it's wicked. Anyway, wild parsnip is sort of related because these are all part of the carrot family, and actually carrots, dill, parsnips, celery are all products that contain a variety of photoaccelerators that can make us vulnerable to sunburn and even extreme burns. Interestingly enough, citrus fruit is another example of that. And they contain these class of compounds called furocoumarins, which are photoaccelerating. And what they do is when you have this compound on human skin, the ultraviolet light interacts with it and it kicks it up to a different energy state, which causes it to release massive amounts of energy, which causes damage within the epidermis. And it can create blistering reactions. And we often see, for example, people coming back from the Caribbean. Oh, I had mixed drinks with my friends, and we had a great time, and the lemon squirted a little bit, and now I've got this rash all over my body, and it blistered. Well, you were out in the sun, and you had furocoumarins from your lemon peel, or your orange peel, or your margarita, or whatever, and that's what it was. And I had a case just about 4 months ago of someone during the late winter who came back from the Caribbean and was like, I don't know what happened, Doc. This rash just came up the minute I got back from the airplane. I'm like, it's not the airplane. Anyway, and it was obviously, she admitted that she had lemons in her margarita. Anyway, so let's talk about some other things that are considerations in terms of sunburn. So the index, UV index is very important here to look at. In Maine, we often get lucky and it's not that strong, but we have seen at times UV indexes in the 8 and 9 range and sometimes even 11. 11 is dangerous. I mean, you can literally burn in a period of minutes without sunscreen. And usually it's recommended when you see 10s and 11s, if you're going to go out very briefly, avoid going out between 10 and 4, 10 a.m. and 4 p.m. With an index of 1 or 2, you can go out for an hour with a light sunscreen and you're fine. And then everything in between. So I would look at the indexes if you're going to spend large amounts of time recreating or hiking or whatever, because the UV index will give you a guide to how vulnerable you're going to be on that particular day. Certain antibiotics can make you photosensitive, and the classic example is doxycycline. I remember when I was in my residency, there was a guy from Nigeria who was, an African-American gentleman who was incredibly dark-skinned, and he had gone on doxycycline for a little infection, decided to go out to the beach and sit in the sun for 2 hours. And he comes into the ED, and he had blisters from head to toe, and we had to actually put him into the burn unit. I mean, it was that bad. So doxycycline is one of those things, of the tetracycline class that is really something you have to be careful. If you get treated for Lyme, be really careful with the sun, for the period of time. And the washout period is about a couple, 3 days. Anyway, sulfonamides, quinolones are other classes of antibiotics. So, quinolones such as Cipro and Levaquin, are also, but they're much less so than the tetracycline class. Non-steroidal anti-inflammatories, ibuprofen, Aleve, a variety of other NSAIDs are going to promote sunburn. They're not, massive, photoaccelerators, but they are significant. On the other hand, diuretics, particularly furosemide and to, some extent butanamide, are significant. And you have to be really careful if you're on a diuretic because you're going to be much more vulnerable to burn. Antifungals are, not quite as significant, but we've seen burns with terbinafine, with itraconazole and the other azole antifungals. Let's go to the next. Oh,
Ask the doctor.
well, before I do that, let me just mention a couple other things. So there is something called sun protective clothing. And what's great about sun protective clothing is that unlike sunscreen where you have to keep applying it, you just wear it and you don't have to reapply it. And there is something called the UPF, which is the ultraviolet protection factor, which is sort of an analogy to the SPF. But the beauty of this is it actually covers all the wavelengths. And so sun protective clothing, whether it's LL Beam or one of the other providers, is great. You want to probably look for clothes that are dark. The lighter clothes will not be as effective. I think that will be helpful. If you get it wet, it will not be as effective because the fibers within your clothing are going to be less densely packed. If you can see through it, you probably are going to get significant ultraviolet exposure. So if your clothes are old and they sort of get a little more pulled apart, as most of the stuff I buy is, because I usually buy secondhand, that's a problem. So just be aware that that's something to be mindful of. The current thinking is a UPF of 50, which is sort of analogous to the 50 sunscreen that we were mentioning, the SPF, is probably the optimal way to go. That will protect you from 98% of ultraviolet, which is a fairly significant amount. And probably, again, corresponds to a 50 to 70 sunscreen, the way human beings normally apply it, not in the lab. Questions?
Well, with regard to clothing, so just a normal, let's just say a normal Oxford shirt, for example,
Yeah, it might be a 15.
might be a 15.
Yeah, but that's probably not enough. So because what they do is they put ultraviolet barriers within the clothing chemically. So it's a completely different class. And so what you do is just ask for, ultraviolet protective clothing when you shop,
Yeah.
either online or in situ in the store. And that's, very useful. I mean, and again, it's a one-shot thing where you can have it for a decade and you don't have to think about it. And it really helps you because if I go out in the garden and I'm wearing my sun protective clothing, then I just have to worry about my hands, my face, and of course I wear, the Australian type hats because I'm supposed to make it look good when I go in the garden. So anyway, but I'm out there a lot. So yeah, I mean, and then you just put sunscreen on your face and your ears and your neck and you're golden. And that way you're covered.
You mentioned SPF 50, which is what you recommended. Does it make a big difference as to what company produces that SPF 50 product?
I don't have a big brand preference as long, I like zinc because one, it's non-toxic. I mean, if you get a cold, you take zinc tablets. I mean, so the worst thing that happens is you won't get a cold, and you won't get a sunburn. And I like the fact that in the near infrared and in the visible spectrum of light, it covers that also. And it covers all of A and all of B. We can't say that about some of these polycyclic aromatic hydrocarbons that are present in the other types of sunscreens that are non-mineral based. And again, since we don't know what amount of ultraviolet A protection actually is present, we're sort of guessing. And I don't like that. And I also like something that's non-toxic, and I sort of also like to stay away from hydrocarbons if I can, just as a principle.
Besides wearing a hat, which is obvious, do you suggest anything particular for hair and scalp?
I mean, what you can do if you're not comfortable with that alone, and it's not sun protective, then what I would do is use a sunscreen on the scalp, and you could use either a foam or a gel, and that would be a great way to go. That way you sort of, in a sense, have double protection.
I once heard that once you get over SPF of 50, it doesn't really matter, so you see these with like 60 and 70.
Well, I mean, that's true, except that if you think about the fact that there's an exponential drop in efficacy with the amount you apply, it depends on how much you apply.
Yeah.
Again, if you're willing to lube up into the sort of greaser thing, I don't think you have a problem with even a 30 probably. But if you're going to use a very thin film, which I have to confess is what I usually do, I usually go with 70, I mean, to be honest. And I'd rather spend a little extra and just not get burned from a monetary point of view, because it's just like, who needs to come into the office toasted? Any other question?
Yes, my concern was about thinking back on your life when you were young and you really I paid no attention to most
Hey, when we were young, I mean,
You didn't
Did
know
they
that?
even have legitimate sunscreens other than the zinc oxide? Not really. And my parents told me, Lee, go out and bake. You didn't get enough. It's good for your vitamin D. You know, I'm sure you do similar things.
So,
Yeah.
so this, if you live foolishly when you're younger, is that like set in place a condition that is going to make the chance of cancer more serious later in life, or do you heal somewhat? How does that work?
So think of it this way. You know, your early exposure will to some extent dictate, at least in part, some of your skin cancers. But we all have things that have evolved over time as we mature. Our immunologic ability to fight off skin cancers changes and doesn't get stronger as we get older, as we mature. The amount of photo damage and environmental damage from a variety of other chemical sources other than just, ultraviolet, whether it's toxic heavy metals, PFAS chemicals, a variety of other things, pesticides and so on, will all impact our ability, both cutaneously and systemically, to fight off cancers in general and skin cancer in specific. So, the idea, I think this is where you're asking the question, is what is the value of treating now, given that we have a lot of damage that we're already, carrying with us? And the answer is, the studies suggest that if you do something now, it's going to be helpful going forward. The incidence may drop from what it would have otherwise done if you've done nothing. So I think it's still worth doing, even those of us who are in our 70s or older. But, and the other thing is, who wants to get sunburned? Anyway, I mean, it's not exactly fun.
And the other part of that, I guess I was thinking too, is I remember as a kid hearing a lecture about people who smoke, and the encouragement was if you stop smoking, your body can bring you back to before you.
Well, it doesn't actually do that. There are two things that occur in smoking. One is promotion, and the other, the promotion means that you're actually promoting the development of atypical cells that already exist. And that promotional effect will wash out after 5 years, but the actual genetic damage is done. And so, you're not turning on those atypical genes without promotion, so that's why it's great to stop smoking, but you still have a finite risk from the smoking. And by the way, smoking will increase basal cell carcinoma, melanoma, and squamous cell carcinoma risks substantially. So, it applies to all cancers, not just, and it's like a 350% for basal, I think 300 for squamous, and 250, 300% for melanoma. So it has a significant impact. But, stopping smoking is going to be good. And the same is true with continuing to protect your skin as we go forward,
Great, thanks.
Of course. Anyone else have any questions?
I have a second question.
Of course.
You mentioned mineral sunscreen,
Yeah.
and I wonder if you just talk a little bit about, I guess there are some sunscreens that have been proven to be somewhat toxic, or they're
Right, well,
ingredients.
there are a bunch that were pulled from the markets.
So how do we best choose?
Well, I think basically choosing the mineral sunscreen is the choice. Because, I don't know what titanium, to be honest with you, I don't know what titanium dioxide does in the human body. It's not really a naturally occurring cofactor, but zinc is. And so I just go to zinc, because I don't know what these other things do, and I don't think the literature does not reflect that we have ubiquitous knowledge. It's an evolving field, and continues to evolve. And hopefully with AI and quantum computing, the rate of drug discovery will massively increase, and we'll have a lot more answers in 5 or 10 years. But, right now, there's a lot of unknown, and I just would rather be prudent and conservative, and so I think zinc sunscreens are a great way to go. And that really will, give you a much higher likelihood of being safe. Because again, if you absorb it, it's water soluble, so if you have an excess of zinc, you pee it out. It's a naturally occurring thing that, we take as supplements when we get colds.
So is it just a factor of reading the label to see if it's mineral based? I mean, I've never even heard of
Yeah,
it
so
before, and
what
I've
you
been
do
using
is you look, and
sunscreen
it'll
religiously.
show, I just bought this sunscreen, my son got married over the weekend, and I just bought this, 45 pure zinc sunscreen.
Yeah, I've never heard of it.
And so, yeah, that's what I went to do. So I'm like, I don't want anything in it, I don't want fragrance, I don't want anything, I just want zinc. And, I try to avoid nano-sized particles just because their absorption levels are sometimes a little crazy, and we don't really need that. It was a, SPF of 45, so it's probably enough.
Well, I might add, I've had some of the first generation LLB clothing that was supposed to protect you from the sun, but I remember distinctly that the label said it was only good for X number of washings. I don't know, remember now what it was, because mine far exceeded it. I've had this stuff for 20 years, but, maybe the first generation, as opposed
Yeah, I
to
think
now, but there was a time when what LL sold had a lifespan.
Right. I don't actually know what the LLB products are right now, to be honest with you.
You and I were talking earlier about the ridiculous heat index yesterday.
Yes.
Somewhat today, which got me thinking a little bit about days in the cooler temperatures in Maine.
Yeah.
And my sister's here, and our father was somebody who had 2 different types of skin cancers, and we used to tease him about putting bullfrog on in the middle of the winter when he would go out. Because he said, well, I want to protect my skin.
Good.
So I guess my question is, what sort of relationship the heat or temperature would have on somebody's susceptibility to, or vulnerability?
So there is correlation with temperature, but the other thing is, when the temperatures are low and there's snow on the ground, there's also reflected light. And so the amount of light that we're receiving in all wavelengths is actually much greater. So on a ski slope, you can get toasted and it's 10 below if you in exposed skin. So again, I think I would wear sunscreens.
So year-round application.
I think it's reasonable. I mean, and again, the other thing is, you want to watch your vitamin D levels anyway.
Yeah.
There are correlates about vitamin D levels in dementia, when they're far too low, and also depression, and you don't want to get toxic either. And so, I encourage people to get their vitamin D levels checked, on occasion, and not avoid the issue altogether. Actually, one of the people who works here came up to me the other day and said, I've been taking vitamin D supplements. I said, well, have you checked your values? She said, no, I never did. I've been doing it for 3 years. I said, why don't you check your values? And came back, she was toxic. So the maximum was 50, and she was, I think, like 63 or something like that. So I was like, stop it. Let it wash out of your system for the next 3 months, and then recheck it. And if you're normal, then you don't need to do anything. And people do think that, being in the higher end of the normal range probably is going to enhance mentation and human function in general. But find out where you are before you start supplementing again, because sometimes too much is too much.
Sorry, I promised my last. Kind of related to.
There are no bad questions except the ones we don't ask. So.
My question's sort of related to John's earlier question, and I'm of the generation that sat out on my dorm roof with aluminum foil and baby oil and wood iodine all over my face, looking for a suntan.
Yep.
And I mean, it's a miracle I have a face today, but I would think, that was when I was 21, not when I was 74, which I don't do that anymore. Is there not something along the way where the skin, rejuvenates, that you slough off?
Remember, we're constantly remodeling our skin, and there are things that you can do that will enhance remodeling, with glycolic acids, tretinoin, which is a vitamin A derivative, or adapalene, or tazarine, or a variety of vitamin A derivatives, which are great for remodeling. They induce genes, which will enhance the resilience of the skin by actually attaching to the DNA itself in the nucleus of cells, and altering their genetic expression. So, I mean, there are things you can do to, enhance things. And not just be a sort of passive recipient.
Does it undo? I mean, can time undo with proper care of the skin after excessive abuse of the skin?
Well, the answer is there's natural remodeling going on all the time, and we are attacking our atypical cells in our skin, just as we're doing it throughout our bodies. But we probably, everyone in the world, probably can't, carries some cells that are malignant. It's just they are unable to proliferate because we are able to keep them at bay. And the same is true of the skin. But in terms of augmenting natural responses, there are a variety of things that we can do. For example, there's a medication called imiquimod, or Aldara, is the branded name, and it is an inducer of something called tumor necrosis factor alpha, which is the way we kill tumors. And it upregulates, it's a biologic modifier, as a cream, it will upregulate this particular molecule in our skin, and it will kill off atypical cells. And there are a variety of other creams that will do similar things through different mechanisms. So there are ways that we can remediate damage beyond what the natural healing mechanisms that we have are by augmenting. Or we can do, there's something called photodynamic therapy where we apply a liquid called glebulin, it's a levulindic acid, and it's a photoactivatable molecule that will preferentially bind to atypical rapidly dividing cells. And after a little waiting period of about an hour, we put you under a blue light at 450 nanometers, which is just blue. You can see it's really blue. And what happens is this will cause that molecule to vibrate intensely and kill the cells by releasing energy into them. And so this would wipe out populations of atypical cells as well. And then there's, 5-fluorouracil, which is a chemotherapeutic agent that's used often for GI malignancies, for example. But we also use it topically to kill atypical cells that are rapidly dividing, because it intercalates with rapidly dividing DNA and stops replication. And that causes inflammation. And a combination of immune modulation and cessation of division will wipe out these populations. So there are a whole bunch of ways in which we can remediate prior damage if you have significant damage. And if you don't have really significant damage and you want to augment, I like the vitamin A derivatives, the tretinoin, gabapentin, and the like. The branded name is Retinate, which people may have heard of.
I have a question.
Yeah.
If you have pre-cancer on your lip, what do you recommend that you put on your lips when you're in the sun?
I would use a lip balm with preferably at least a 30 or more, but put it on really heavy. Or if you can get a 50, that'd be fine. As a preventative. But I like them because they have a lot more waxy esters and they're heavier. They're not going to just disappear when you move your lips together. And so the wax is a really great way to hold it there. It's also great for moisturizing too. Going back to the idea that skin that is properly, that has a proper skin barrier is going to be more resilient to ultraviolet damage. Sorry, you can ask me.
No, I was just going to ask about the sunscreens. Do you feel the lotions or the spray? Because you see a lot of people spraying, but it doesn't seem to go.
I think it's a cosmetic preference because I think the problem that I see in general is, how often are we going to apply this? How motivated are we going to be? So if you like the product, you'd be more motivated to use it. I know I would be. The ones I don't like are usually in the closet and I just put my hand on
With the creams, at least you can see where you're covering the spray kind of stuff.
True, well,
I
I
see
mean,
people
then you have
doing
to
it at
just
the
really
beach.
go over it and make sure you've got it all and rub it in, which is what I do with sprays. But I tend to like lotions personally because I think that they're, they're light and they sort of disappear and they don't feel onerous. I don't really like the greasy feeling particularly.
Yeah, that's what most of the sprays
But,
are.
there are also cultural groups that prefer, greases. And so, it's really a matter of, and personal, people within those groups have as much variation as the groups themselves. So, it's really a personal preference. Whatever you feel more comfortable with, I would encourage you to use because you'll use it more often.
And the zinc isn't like the white nose, is the zinc?
There are a whole bunch of different colors, but they usually have some sort of tint.
So the one you use does?
Yeah, it's a little slightly yellow, but, I'm not trying to look like a politician. Anyway, so, thank you all for coming.
Thank you so much.
Lee, thank you very much.
My absolute pleasure, Brian.
Appreciate that.
Of
And
course.
thank you again all for joining us this evening, and thank you to LCTV as well for bringing this presentation to the community also. So thank you, everybody.
Everybody have a great night. Just careful in the heat.